bending movement that decreases the angle of the joint. All right, so students don't have any issue with this normally. When I say flexion at the elbow, no one would ever miss this, right? Flexion and extension. Nobody would miss that. Okay, what about in my wrists? Flexion and extension. Now I ask you, if I define flexion as decreasing the angle of the joint, that makes sense, right? I decrease the joint angle, okay? But what about when I do this? It depends on which joint angle you're talking about, right? See that? So if I'm thinking about the joint angle here, I'm decreasing it. Okay, but normally people don't get mixed up with this. It's not a problem. Okay, but how about this one? My arms are doing this. Yeah? So this is flexion and extension, the shoulder, right? So which one is flexion and which one is extension? Yeah, so this one is flexion. So we normally think the forward decrease in the angle is flexion and the posterior movement as a decrease. Although I can see where people could get confused with that. So I'm going to point those out to you, those places. And then AB and adduction, very common terms we need to use. And circumduction, I want to compare circumduction to pronation and supination for you. All right, there's the gliding. There's what I was just talking about, flexion here. We can't really say, this one helps me illustrate that. We can't really say, you notice in the definition, right? It says bending movement that decreases the angle of the joint. It doesn't say decreasing the joint angle anteriorly, which would be great. I would love a definition like that, yes? But we don't because you can see here that wouldn't work in the knee. If we did that, we'd be calling this extension. So really, the anatomist is thinking more in terms of the most common natural action. Yeah? Because this is actually posterior. And if we're talking about this joint angle right here, I'm actually increasing that joint angle, but yet we call it flexion. Okay, I'm not trying to confuse you. I'm trying to point out to you the terminology. Most people wouldn't miss that. Flexion at the knee, extension at the knee. Got it. Okay. How about at the hips? So I think most of you would say, if I asked you before today, okay, is this flexion or extension? You'd probably say flexion. Is that what you had said? And you'd be right. That makes good sense, okay? Then what would you call this? Extension, right? But that's not right. In anatomy terms, this is extension. In anatomy terms, this is hyperextension. So at the hips, we have flexion, extension, and hyperextension. All right, let's do the head. So with the head, if we do the same thing with the head that we do with the hips, then this would be flexion, and this would be hyperextension. So this is extension right here. So we can use ligament names because we've learned these, yes? So if I'm thinking about ligament names that are holding the vertebral bones together for my head, give it a specific example, yes? If I'm thinking about this, okay, so I bend my head over this way. I bend my head over this way. So now, what is allowing that to happen are the zygapophyseal joints between the superior and inferior articulating facets of the cervical bones. Yes? Yes? So that's what's allowing this articulation. Those things, those synovial joints are actually sliding, yes, to allow that to happen between the cervical vertebral bones. What ligaments are becoming stretched within my vertebral column? So the one that runs from the external occipital protuberance all the way down the spinous processes, we named it the supraspinous ligament. Ringing bells? So if I If I do flexion at the head, I stretch the supraspinous ligament. Good? What is the other major ligament that the supraspinous ligament is attached to in the cervical region? Right up here. The trapezius goes in there. The nuchal ligament, yes. So that nuchal ligament will be stretched there, all right? So let's take it all the way down now. The nuchal ligament all the way down to the spinous processes. I pass through the bone, through the lamina, through the spinal cord, and I'm right on the back of the body of the vertebral bone. What ligament is that? So the bodies of the vertebral bones, I showed you a picture of this, bodies of the vertebral bones, there's a ligament that runs right down the back of them, and another one that runs right down the front of them. Remember? We call them the posterior and anterior longitudinal ligaments. So which one of those ligaments is being stretched with flexion? The anterior or the posterior? The posterior longitudinal ligament. So this is an opportunity to review. Yes? You're seeing these things. Think about what's happening. So I bend my head over. What's allowing that? The joints between the cervical bones. I know how those joints are made. All right, well, what ligaments are being stretched? The supraspinous ligament, the nuchal ligament, posterior longitudinal ligament. These are the pieces that get stretched whenever we do this with our backs. And you can do it anywhere, right? You can do it here with flexion. Think about those ligament names as you do that. So I like to use one example here to remind you the names. All right? This one confuses students, dorsiflexion and plantar flexion. It confuses students because of a couple of reasons. The most blatant reason it confuses students is because of the names of the muscles that we will attach to the feet to do these things. As it turns out, there will be muscles attached to the feet that are called extensors. But there is no such thing as extension at the ankle. It is moving your toes superiorly, moving your foot superiorly to decrease this joint angle, we call dorsiflexion. You probably would have called that flexion. But let's don't do that, because to move the foot the other way, you would think extension. In fact, the ballet people, the dancers, they say, what should you do to your toes? They don't say, you're going to flex your toes, you're going to extend. You need to be fully extended here. That's not the term in anatomy. Even though the muscles have those names. The term is plantar flexion. So nobody refers in anatomy as the action here at the ankle as being extension. It's dorsiflexion and plantar flexion. So that's confusing. All right, abduction and adduction. Simply put, you'll never forget this one. To add the arm or the leg to your body is to adduct. To subtract it is to abduct. I'm subtracting it from the body. I'm abducting. I'm abducting. I'm adding it to the body. I'm adding adducting. Circumduction is sometimes confused with pronation and supination, which I have on the figure to follow. This figure right here. So supination and pronation are terms we only use in reference to the arms. And so to supinate is to put the arm into the anatomical position. Thumb's lateral, ulnus medial, the bones are not crossed. To pronate, there are two muscles in the arm that do this. Do that later. Pronation happens this way. So you move, I think of rotation, but it's really pronation. So the head of the radius is rolling. It is rolling in the articulation of the ulna there, the radial facet in the ulna. It rolls there and it allows you to pronate. This action, supination and pronation, is not circumduction or rotation. So this shows you rotation. So let's go back to the first one. This shows you circumduction. Okay, so what is the difference between circumduction, rotation, and supination, pronation? All right, so let's do that. To circumduct is to create a cone. there's a point on this side and a wide piece created this way by the joint movement. So circumduct means create a cone. To rotate means to twist in a barrel. No cone, twist in a barrel. You don't get to move about, yes? You're rotating, twist in a barrel. You're not creating any cones here. And supination and pronation is unique to the radial ulnar articulation. Cross the radius ulna. Cross the radius and ulna. That is to pronate. Uncross them is to supinate. So those are the ways to remember circumduction, rotation, and supination, pronation. All right. The feet can also, in addition to being dorsiflex and plantar flex, they can be inverted and everted. People don't want to miss this. Turn your feet in, I invert. Turn the feet out, I evert. So inversion really takes you in your mind where you're supposed to go. Inversion of the foot here at the ankle joint. Protraction and retraction. Now, I taught you the jaw just a moment ago. If I said, show me depression and elevation at the jaw. Yeah? Nobody has a problem with that. Depress, elevate. In fact, you could name the muscles. Yes? What muscles do this? The masseter, temporalis, lower medial pterygoids. What nerve does that? That would be the mandibular branch of the trigeminal nerve. And what is the name of the skull bone hole that the mandibular branch passes through? The foramen ovale. Yes. Okay. So you've learned these things. Okay. So I could do depression elevation. Nobody would have a problem with that. You know, we could probably stretch that to say the jaw can flex and extend. But nobody says flex and extend. They say depress and elevate with the jaw. What about circumduction? Can you circumduct the jaw? Yeah? I can circumduct here. What about retract and protract? Retract, pull it back toward the body. Protract, push it out away from the body. What about the temporomandibular joint would allow this thing to protract and retract? Did you hear me describe the joint movement a moment ago? What happens to the mandibular condyle on that articular disc as we open and close our jaws? It slides, yeah? It slides along that articular disc. So what is happening when you're protracting and retracting? You're sliding the mandibular condyle on that articular disc within the joint. And here's the elevation depression of the mandible. All right, now that's enough introduction to joints. I can actually teach you some of the more interesting ones as we finish the muscle attachments. Okay, so the deltoid, which we've talked about on several occasions now, is on the shoulder. So here's what I'm going to do. For the last 12 minutes of class today, I'm going to dissect the shoulder for you. You can learn the pieces and parts of it. So we've dissected the jaw, we've dissected the back, we've dissected the face. We're going to dissect the shoulder. So the large muscle here, lateral and superior on the shoulder, is the deltoid. It shares some attachments with the trapezius. It shares attachments on the clavicle and the spine. Now, by saying shared, I do not mean they attach to the same location. They share in the sense they're on the same bone. Now, I am not going to ask you about the margins of the bones. We've entered a new zone when we start talking like that. Okay, so I would expect you to know that it attaches to the clavicle, acromion, spine, and I expect you to know that the trapezius attaches to the clavicle and the spine. So they're both on these bones. That's the point. It's surprising for the trapezius because you don't think about the trapezius as being on your front of your body, but it is. The clavicle then is, the deltoid then is no surprise. And you can see it here. It comes across and attaches to the deltoid tuberosity. Now the deltoid, in fact, gets innervation from the axillary nerve. So I don't have it here, but you should go back and look. The axillary nerve, you need to be able to trace this across the brachial plexus. It gets information from the posterior cord, which gets information from all three posterior divisions. So you should be able to track that. Picture will help you answer these questions. The axillary goes to the deltoid. Now, if I take the deltoid off of the arm, the next thing that jumps out at you, the very obvious piece here, is that there is a tendinous, a fused tendinous support to the shoulder. And you can see that tendinous support here looks, in the eye of the anatomist, it looks like a cuff, almost like a sleeve, that has been wrapped around the shoulder. Most of the mass of that sleeve is on the lateral, superior, and posterior aspects. So you can see that here, lateral, superior, and posterior aspects. That's where the mass of that cuff is. The primary reason for this cuff of tendons is to add stability to the joint. That is, these tendons help to hold the head of the humerus in the glenoid cavity. And they are referred to popularly as the rotator cuff tendons. They include the attachment number 1 of the supraspinatus, which attaches here in the most superior margin of the greater tubercle, and then it has its origin over in the supraspinous fossa. I'm going to show you a picture. Yeah? Here it is right here. The supraspinatus here extends here beneath the acromion. This is a posterior view, and attaches to the lateral margin here of the greater tubercle. The next one down is the infraspinatus, and it's fused in here with the supraspinatus on the greater tubercle. And you can see the infraspinatus here coming out of the infraspinous fossa, passing across on the posterior aspect to attach to the greater tubercle, on the back, on the posterior aspect of the greater tubercle of the humerus. The third one is the teres minor. The teres minor attaches here. You can see the teres minor right here. It attaches to the lateral border of the scapula and then makes its way up here to attach to the greater tubercle of the humerus. Those are the three big ones, and their aspect is superior, lateral, and posterior. That's the way the cuff is really arranged. What that means is it is very difficult to move the head of the humerus in that direction. So the head of the humerus is a large head and a small fossa, which means it is a very mobile joint. So we need some things in place to make sure the head of the humerus stays in that fossa. And these are major contributors here: the supra, infra, and teres minor. Now, the only muscular support on the front here supporting this articulation is the articulation of the subscapularis. So here is the anterior view, where you can see the subscapularis here attaching in the subscapular fossa and moving across over here to attach to the anterior tubercle. So these are the 4 famous muscles of the rotator cuff. So whenever you hear people talking about shoulder injuries and they say there's a rotator cuff injury, this is what you're talking about right here. Now, if you had to guess, which of these muscles tends to be injured more than the others in a shoulder injury? What would you think?
Subscapularis.
Okay, why would you say that?
It's the only one in the front.
Okay, so from one point of view, Jared, you are correct. So if you're going to disarticulate the head of the humerus out of the glenoid cavity, if some sicko crazy person says, all right, I want to dislocate my shoulder, you're an anatomist, tell me how to do that. What do you tell them? Which way will it come out easiest? So will it be easy to move the head of the humerus out that way? Why not? There's three tendons there holding it in place. So the easiest way to move it is this way, right? Okay, now, what else would you know if these are the three attachments from the scapula over to the humerus holding it in place? Where is there something blatantly missing? So if my shoulder, if my arm is abducted, where is the support missing? If it's abducted, so if I lift my arm this way and I abduct it, I have these tendons across here and I have one right here. Where's the support missing now? Under here. Yes? The support under here is missing. So can you tell the person now what to do? Abduct your arm, and then from this direction, forward and down. Yes? Forward and down onto the shoulder, and you can move the head of the humerus out of the glenoid cavity. There's nothing under here holding it. So this, you're right, this would be in a shoulder injury where somebody was hit, playing rugby or whatever, and they're hit across the top of their shoulder, they've dislocated. This is where it happens. They get hit from the back, moving their shoulder down this way, and it dislocates. Good. Now, wouldn't it be useful, I'll come back to the nerves. Wouldn't it be useful then to have some bursa in place protecting these guys? So over here you can see that there are several named bursa. So this one I mentioned earlier, the subdeltoid, does it make sense where this guy is located? Right, the deltoid comes right across the top here to attach to the deltoid tuberosity, anterior lateral. So that would make sense. What about this guy? Let's do this one. What is the purpose of this subscapular bursa right here? This is the coracoid process, and the subscapular bursa is right here. So what muscle is in here? This is an anterior view. This is the subscapular fossa. So the subscapularis is here, and it comes across here. It's been torn off here, obviously. It comes across here and attaches to the lesser tubercle. So the fibers of the subscapularis are in close proximity to the coracoid process. So how are we going to keep the subscapular tendinous fibers from rubbing against that process? Did y'all see it? There's bursa there. Yeah, so it makes perfect sense where this guy is. How about this one right here? The subacromial bursa right here. This is the supraspinatus, and here's the tendon of the supraspinatus. You see what that does? It protects the tendon of the supraspinatus from the acromion. So bursa make good sense for their locations in the joint. Okay, now when we did the clavicle before, I showed you this picture of the coracoclavicular ligament. These two pieces of the coracoclavicular ligament. Do you remember what I said about that? By way of reminder? They're attached to the conoid tubercle. The conoid tubercle here on the clavicle, on the inferior aspect, and they're hanging onto the coracoid. They're not really for stabilizing the shoulder, are they? If the clavicle keeps my shoulder lateral, the coracoclavicular ligament suspends the upper extremity. So what is the weight that the coracoclavicular ligament is holding up? The upper extremity. What else is holding it? So this is what holds us in this position, this ligament attached from the clavicle to the coracoid process. That's what I pointed out to you before. Now, of these names over here, and certainly don't memorize the others, because this is the important one I pointed out to you on the conoid tubercle before, but of these named ligaments over here in the shoulder, which one of those named ligaments actually helps hold the head of the humerus in place? So you learn the names of the rotator cuff muscles, and they're helping hold it in place. But which one of those major 4 named ligaments holds the head of the humerus in place? Its name will tell you. Okay, so the name of this ligament is from the coracoid process to the humerus. So the coraco process to the acromial process, that doesn't hold it in place. The acromia to the clavicular, that doesn't hold it in place. The coraco to the clavicular, that doesn't hold it in place, but this one does. So in addition to having rotator cuff muscles from the scapula attached, there's actually a ligament that passes from the coracoid process over to the head of the humerus and holds it. And what's not pictured on here is there are actually 3 ligaments within the cavity. 3 glenohumeral ligaments that help hold the head in place. So if I'm talking about the glenohumeral joint, the first thing I think is it's not stable, which means it's very mobile. It's very mobile because it's given up stability. It's a big head and a shallow cavity. But is it in fact stable? Most people don't separate their shoulders in life. It normally takes something abnormal, right? So why aren't humans walking around with separated shoulders all the time? Because we've got good things in place to hold it there. The deltoid contributes. The rotator cuff contributes. The coracohumeral ligaments, the glenohumeral ligaments hold this thing in place. And then finally, and then we'll do the nerves next time. Finally, this picture, I want to show this, leave you with this one, yes. The bicep, which is a flexor of the elbow, the major flexor of the elbow, is also attached to the coracoid process. So the bicep attachment to the coracoid is not necessarily going to do anything for this joint. But look at the other head of the bicep. This is the short head. The lateral head of the bicep passes up through the intertubercular groove. See it? So all the rotator cuff muscles, the big 3, supraspinatus, infraspinatus, teres minor, they're all here. Right here is the subscapularis coming across here. And then there's a tendon that passes up through this groove to attach to the rim of the glenoid cavity. It crosses right over the top of the head and attaches to the scapula. It's not attached to the humerus there. And it's really important in holding the head up into the glenoid cavity. It's so important, in fact, that there's this beautiful ligament here, shown right here, that actually holds the tendon in place. The tendon is passing up through here, and there's a transverse humeral retinaculum that holds that tendon in that groove. Now that is a nasty look when you see somebody tear that. Now, if you have a tendon, I have to shut up. If you have a tendon that is next to a bone, is that good? That is not good. Because if you rub on the bone, what's going to happen? It's going to, yeah, the tendon's going to get torn up, but it's going to get torn up primarily because the bone's going to respond to that. If you rub on the bone gets bigger there. More bony material. So if all of your life, every time the tendon of the long head did that, rubbing in that intertubercular groove, it did that all your life, what would happen as you get older? What would happen to the groove? There's a pocket it's sitting in. So if it's rubbing in that pocket and you get bony deposits because of that, the groove gets shallower and shallower, right? Until finally, the tendon won't stay there anymore. We can't allow that to happen. What would you do to protect the tendon rubbing against the bone? What would you do? From what you know today? Put a bursa there, exactly. So we call these bursa that wrap these tendons, we call these bursa that wrap these tendons. I will show you that picture on Friday. There is a sheath. It's called a tendon sheath, a synovial sheath that wraps it. It wraps the tendon. We'll start class with that on Friday. I'll finish the shoulder and we'll move on down